Good evening, everyone. In the history of the church, and certainly in the history of the church in our country, the apostolates of education, healthcare, and social services were begun and carried out for much of that history by members of religious orders or communities. Our speaker this evening stands in that tradition and has made a very substantial contribution to it. Sister Carol Keehan, who is a daughter of charity, is the 9th president and chief executive officer of the Catholic Health Association in the United States. To put some perspective on that, the Catholic Health Association is comprised of more than 600 hospitals and 1,600 long-term care and other health facilities in all 50 states. Catholic Health Association is the largest group of nonprofit healthcare providers in the nation. So every day, 1 in 6 patients in the United States is cared for in a Catholic hospital. Sister Carol assumed her duties in that position in October of 2005. Prior to joining CHA, Sister Carol worked in administrative and governance positions at hospitals that were sponsored by the Daughters of Charity for more than 35 years. Sister Carol holds influential roles in the governance of several healthcare, insurance, and educational institutions. In 2014, she was elected as a member of the National Academy of Medicine, which advises the nation and international community on issues of vital importance to public health. In 2010 and the ensuing years, Sister Carol played a central role in advancing the Affordable Care Act and ensuring that it continues to effectively provide health insurance to vulnerable people and working families. Sister Carol has been a representative to the International Federation of Catholic Healthcare Associations of the Pontifical Council for Pastoral Healthcare at the Vatican. In addition, she has been a member of several health, labor, and domestic policy committees of the United States Conference of Catholic Bishops, and she now serves also on the Finance Committee of the Archdiocese of Washington. Her numerous awards and honors include the Pro Ecclesia et Pontifice, which is the Cross for the Church and the Pontiff, which was bestowed on her by Pope Benedict XVI, the Seton Legacy of Charity Medal, and the Catholic Charities USA Vision Award. In 2010, Time magazine named Sister Carol one of the most 100 influential people in the world. She's also appeared on Modern Healthcare's list of 100 most influential people in healthcare for the past several years. But most important to all of us, I suspect, is that she is a former trustee of the University of St. Thomas. Sister Carol earned a Bachelor of Science degree in nursing and a Master of Science degree in business administration, and has been awarded many, many honorary doctorates. For 10 years, while I worked at Catholic Charities USA, I was honored to work with Sister Carol on several initiatives, and I can attest to the passion that she brings to this work. Her voice is well respected and carries gravitas in debates surrounding healthcare. I'm privileged to have her as a friend, and it is an honor for the University of St. Thomas to have her here this evening as our speaker. Would you please join me in welcoming Sister Carol Keehan?
Thank you very much, Larry. That was a kind introduction. I'm always called to remind people when I'm introduced. Is that better? And people have gone through that very long and tedious CV, that when you hear things like Time magazine said she was one of the 100 most influential people in the world, don't get too excited. You have to check who else is on the list. It's me, Lady Gaga, a couple of dictators. It is not the communion of saints. So it's a great privilege to be here. I've fallen in love with the university during my time as a trustee, and continue to stay involved with from a distance and through some foundation work with what's going on in the university. And you have so much to be proud of in this great university. So I'm very grateful, Paul, for the invitation to be here, and I look forward to. I was telling Stephanie, the dean of your business school, that I just did a talk for the MBA students from the university when they were in D.C. last week. And Senator Durenberger, who has done so much at your School of Business, when Senator Durenberger calls all of us who have been in D.C. forever and ever, come out of the woodwork, and there's nobody that can get that many people together to give a free talk to his MBA students than Senator Durenberger. I said to Stephanie, you have the best array of speakers and the most complete array of speakers that any other university gets when they come to Washington, and it's because of Senator Durenberger. It is an honor to be with you, and Paul has asked me to talk a little bit about Catholic health care and sort of the role of Catholic health care, and a little bit about its history, and a little bit about where it is today and its role in the Affordable Care Act, and then some of the social justice principles that we deal with healthcare in this nation today, and sort of my thoughts on them. They might not be yours, and I'm happy to hear other perspectives, and I'm certainly happy to take any questions as well. Catholic healthcare has a long history in this country. Did you ever see so many nuns? In this country, from the 1800s with the Ursuline sisters coming to, no, it was before the 1800s, I'm sorry, earlier to New Orleans, when New Orleans was still part of France. And there's a very, very famous letter written by Thomas Jefferson when they did the Louisiana Purchase. The sisters were very upset because they had built schools and hospitals in New Orleans, and for them they were building them in an annex of France. And now that this rebel country was going to take over, and what would they do to the sisters? Thomas Jefferson actually went and had tea with them and assured them that the country would always recognize their right to care for patients according to their beliefs. And then he put that in writing. So when we were having some of the little challenges, we would wave that letter at politicians. As Larry said, religious women in particular, although some religious brothers in this country, but predominantly religious women have done the development of hospitals around the United States. And we are, as Larry pointed out, we're a large, large presence in healthcare. This is sort of where you'll find us in healthcare. And some of the statistics about how many hospitals we have, how many are trauma centers. You'll also see in this the number of admissions we have. We have lots, and over 20 million emergency room visits. So we have played and continue to play today a very big role in the health of this nation. And that's very important. And I would say there are many, many people in public life who have come to appreciate the fact that Catholic healthcare is a very large piece of this country's health infrastructure. And when you look at the top 10 largest health systems, we're 5 of them in this country. And you say, you know, this is a huge effort from a time, if you remember, a time when sisters didn't get out of the convent much, never ate in a restaurant even, and you have to say, wait a minute. They built the largest healthcare system, not-for-profit system, the world has ever known. It was not exactly what would have gotten you a AA bond rating from Standard & Poor's, or it wouldn't be a business plan that would attract Goldman Sachs. But look at, what it has become, and look more importantly at the good it has done and why it has done that. Catholic social teaching, and this is to some extent poorly understood, but the position of the Church has always been that health care is a basic human right. Pope Benedict said very clearly, healthcare is a precious asset to which we must dedicate proper equipment, resources, energy, so that the greatest number of people have access. It is the moral responsibility of nations to guarantee access to healthcare for all their citizens, regardless of social and economic status or their ability to pay. Justice in healthcare should be a priority of governments and international institutions. I can tell you many, many times I have been, and many others have been, really slammed for echoing that statement and for calling and challenging our government and our political leaders to take that responsibility seriously. You look at documents of the Church that talk about Caritas in Veritate, talk about the desire the common good and strive towards it is a requirement of justice and charity. And I say over and over again, it is important to remember that giving people the health care they need is not charity. We may have it listed on books as charity care, but it is justice. And our Church's teaching in this has not been well mirrored in the laws of our country and in the choices that our country has made. And it has caused a lot of challenge to people. Pope Francis, who talks very clearly about this, says, "The poor and the suffering you will always have with you. Jesus warns you." And the Church continuously finds them along her path, considering those who are sick as a privileged way to encounter Christ, to welcome him and to serve him, to cure the sick, to welcome them, to serve them is to serve Christ. The sick person is the flesh of Christ. But Pope Francis is a very, very inspirational guy, but he's also very much a realist. And he says very clearly, if there's a sector in which the disposable culture makes one see with evidence its painful consequences, it is precisely that of health. In the health realm, the business model has been adopted indiscriminately. And that is very true in the healthcare structure in the United States, more true than in any other industrialized nation. Our Catholic bishops have said so clearly that the Catholic tradition teaches that human dignity can only be protected and a healthy community can only be achieved if human rights are protected. Those are the kinds of things that our Church has been teaching and teaching. And yet, it's certainly anything but true in our nation. And Catholic health care, for the hundreds of years that it's been in process, has a privileged position and perspective on the need for health care for all and the suffering that's caused by the lack of health care. And therefore, we had a great responsibility to be part of the solution. And I would say to you that our organization, the Catholic Health Association, saw very clearly that we had to step up to the plate. And it was probably 2 years before the election of President Obama. And we thought the nation might be getting to a tipping point for many reasons that I'll go over with you. So we wanted to be clear, and we wanted to be prepared. And our United States healthcare system was unsustainable. It was getting to be such a huge piece of the GDP. It was unfair. It was inefficient. I mean, there's no question that there are many pockets of excellent health care, but our health care system is not excellent. Our health care delivery system is not excellent. You have so many issues where it doesn't serve the people of this nation. We had approximately 50 million people uninsured. We had millions more underinsured, who had a policy, but it didn't really give them the protection they needed when they got good and sick. And that had real consequences. The Institute of Medicine, now the Academy of Medicine, did a study, and they said there were 18,000 preventable deaths every year due to a lack of access to health care. And a lot of those were diabetics who couldn't afford their insulin, couldn't get test strips. A lot of them were people who had a little bit of blood in their urine or a little bit of blood in their stool and just said, well, I've heard cranberry juice is good for this, but couldn't afford to go and get a mammogram. And these are people that when they finally had to come to the healthcare system, it was too late to do anything about it. You could do palliative care, you could do a little bit of chemo, but it was just too late. Or they were in a diabetic coma, or they had so much damage to their heart, there wasn't anything that could be done. So 18,000 preventable deaths a year in the richest nation in the world. We had clearly the big donut hole in the Medicare program where the elderly often were choosing between food and medicine. We had over 9 million children in the richest country in the world uninsured. There is no way that you can even think of a valid excuse for a child not having health insurance. And so we went on to look at the fact that over 50% of personal bankruptcies in our country were due to health expenses. We looked from the pro-life perspective. Our national abortion rate was coming down. It was at 8%. But among low-income women, it was going up, and it was already at 18%. And it doesn't take a genius to figure out why these women feel like they have no option but abortion, because they can't afford a pregnancy, they can't afford to care for the child afterwards, and they'll have no health care for themselves or their child. You know, and the most vulnerable and with serious illnesses that would not only lose their coverage, but if they moved to another place, they couldn't get new coverage for the healthcare issue that was the biggest healthcare issue they had. And if they spent up to a certain amount in their premium, in their policy, everything else they weren't covered for. And I remember a woman here telling me at St. Thomas when I gave a talk here in the height of the fight for the ACA, during which I was pretty aggressively picketed, I might add. It wasn't on campus. It was I forget where it was, might have been wherever the Good Friday Club is. And I thought, okay, this is Good Friday. But anyway, talking about having a husband and a daughter with very serious chronic conditions that were life-threatening, and petrified they would reach the upper limit, because then they would be on their own for all their medical expenses. And you know, those kinds of things. You have a child born with a heart disease. You have a young person who gets cancer, or anybody who gets a pretty serious cancer that's going to hit the limit. All of a sudden, what you need insurance for most, you can't get any coverage. And you take a look at whether an American does the study or someone from another country at the largest industrialized nations out there and their healthcare systems, and you look at them from the perspective of quality of care, access, efficiency, equity, long productive lives, and then you look at them from the cost. In all of the categories, we score at the bottom, except in healthcare, and we are at the top of the heap by more than twice in most cases. That's a pretty significant problem. And, you know, we make a lot of jokes about the British healthcare system and the Canadian healthcare system, and people often say to me, you know, you have to wait for 6 months to get a knee replaced in Canada? I say, I guess you do, but most people that I know in the United States have put it off for at least a year, so I don't think it's, you know, that it's not life-threatening. And they don't have to wait for the life-threatening stuff. So with those things in mind, we said, yep, we do need a national health reform. And the first thing we said was we were not going to write the plan. We were going to develop some concrete positions that would then drive the principles that we would make. And we did exactly that. We spent a lot of time before the election coming to a vision for United States healthcare, for the transformation of it. And the first principle was the protection of life from the moment of conception until the moment of natural death. We were very, very clear. We never equivocated at the Catholic Health Association on this point. But we also said when it came to national health reform, and it was why we did the vision thing, so that if somebody, we didn't have a plan that we were trying to sell, we had principles. And if somebody had a plan, they wanted us to listen to it, we could listen to it and say, how does it match up against our principles? So we were not on this guy's team or that gal's team. We were on the team to achieve these principles. And we also were very clear with folks that we would not compromise on principles, but we would compromise on preferences. And that was very helpful when we got down to the wire, because I will tell you the Affordable Care Act was not the bill I would have passed. It was not the bill President Obama would have passed. And so it's not, we have never seen it as a perfect bill. We've always seen it as a bill that could do a lot of good and that we would move to improve it. But we never saw it as a perfect bill. The Catholic Health Association, many of you may remember, had a significant challenge in supporting the passage of the Affordable Care Act. We were adamant to try to make the Affordable Care Act work. In all honesty, one of the real challenges we had was the misinformation put out there. And from the perspective of Catholics, the biggest piece of misinformation that was put out there was that if you pass that bill that the Democrats have written, you will do the largest expansion of abortion coverage in the history of our nation. And so, you know, what bishop wants to do the largest expansion of abortion coverage in the history of our nation? Clearly, we had worked so hard to make sure that wouldn't happen. And the president, when he talked to a joint session of Congress, had said very clearly, there will be no federal funding of abortion in the Affordable Care Act. The bill itself says just that clearly. There will be no federal funding of abortion in this act. In addition, the president did an executive order on top of that to say there will be no federal funding of abortion by the Affordable Care Act. And some people said, well, an executive order can be changed. And I said, yes, an executive order can be changed. This is on top of the bill. But an executive order freed the slaves, so, you know, it can be pretty important as well. And then, in addition, we did what they call a congressional colloquy, you know, where 10 years later the Supreme Court is hearing a case and they're saying, what did Congress mean by what it said? In order for that not to happen in a few years after the bill was passed, with a challenge to cover abortion, the House was in session, and Representative Waxman, who headed up the committee, and who himself is pro-abortion, had to respond to a question from another representative saying, does this bill cover, or ever does Congress intend this bill to cover abortion? And he said, the bill is intended never to use federal funding for abortion. So we did that. We got a lot of folks like Timothy Joust, who's probably the best health care lawyer in the country, and Bart Stupak, who is a very pro-life legislator. And everybody came out saying that this would not only not cover it, it would help bring down the abortion rate. We then got the Congressional Research Service to look at the bill and say there's no federal funding. We had HHS say there is no federal funding, and we are very clear on that. However, we never got the support of the bishops, and we actually had the opposition. And I would say, in fairness to the bishops really wanted universal health care. They got very, very bad advice from some of their staff members who were influenced by others. And it was very difficult to be out there for the bill and having the bishops' conference being opposed to it. But it was important, it was very important to stand for the truth. And so the bill got passed, and it was as significant a step forward as the 1965 Medicare and Medicaid. And we took a lot of heat for it, but it's interesting when you look at Joseph Ratzinger, who became Pope Benedict, talking about the importance of conscience and what it means that conscience is the most binding claim. And we had certainly a well-formed conscience. We knew what was there. We knew the suffering of people that didn't have it. We knew what it was doing to the abortion rate among low-income women. And so we followed our conscience. Interestingly, the Holy Father also said, after he was Holy Father, talking about the need to deal with the basic problems and difficulties that women are dealing with, and that the credibility of what we say as church depends on what the church herself is doing to help women in trouble. So it's very clear that the bishops wanted health insurance, but they got very, very bad advice. Now, in fairness, let me say this. The bishops in the last effort we just had when Senator McCain did his famous thumbs down when the House and Senate tried to destroy the Affordable Care Act, the bishops wrote 4 letters asking the Congress, and they were very good letters. They had great statistics in them, great points in them, asking the Congress not to destroy it. It had been such a big help. So, you know, it was a painful moment. We tried to handle it with dignity, and we tried to handle it as Christians who differ on an important subject profoundly, but it was a very painful moment. And so hopefully we've all learned something from that. And when you look at the progress through the ACA, early on as we began to make progress, it was, a lot of people look at it as helping the poor. Well, it did help the poor. But the other thing that's equally important is it helped middle and upper middle income people a great deal. It did reduce the number of uninsured Americans and give them improved access. In the last When I did this, the last time people signed up, we had 11.7. That number's just been corrected to 11.8. And the people that were most at risk, and we really tried to write that bill aimed at the people most at risk, young adults, Latinos, those with low and moderate incomes, and they did. They made the greatest gains in coverage. We got rid of the copay for preventive care so that you can get an annual physical, you can get a mammogram, you can get a colonoscopy without a copay. Now, you might say for people in this room, a $25 copay for a mammogram is not going to keep you from getting a mammogram. But for a single mother with 3 children, it may be the difference between filling her child's prescription or food for the next 2 days before payday. And it's always the thing that goes last. Medicaid expansion is now covering millions more vulnerable families, even with the 23 states that have still not allowed for the expansion of Medicaid, although it's 100% funded. There are no more denials due to pre-existing conditions. You not only can't deny people, you can't charge them more. There's no lifetime limit on coverage. A majority of adults with the new coverage hold really positive views of their new insurance. The Medicare donut hole, that was the hole that after a certain amount of prescriptions in Medicare, all of a sudden, for the next 3,000 or 4,000 in medications, the elderly person was on their own, and when they reached that, then they could start using Medicare again. That left a tremendous problem for the elderly. That has been closed. A majority of the adults that got new health care plans said they would never been able to get access to care prior to getting that insurance. And I can tell you, in West Virginia, where they got the second highest improvement in the percent of people that now had care, or now had insurance. And what many people said from West Virginia wasn't how great it was that they could get their physicals and their condition taken care of. They said it stopped them from thinking about suicide. Because one woman put it so well, she said, I have diabetes, I can't work. She said, I have no insurance, I have no savings, I've taken as much as my family and friends can give me. My church's little charity fund has given what it can give. There's nobody else that can help me now, and I can't expect my family to do any more. And, all she saw was herself as a burden. Now, she can get her test strips. She just brings her card. She gets her insulin. She gets her syringes. Makes such a difference. And so if you look at, in 2013, we had 20% of adults who were 19 to 64, and that's millions of people. We got that down to 13%, and we still hadn't had those 23 states open their Medicaid program, and when they do, it will do even better. And then we had an election, and then we started taking things away and creating challenges for people to get enrolled. And we have to think about that and talk about that. But look at what this really did. And I remember Professor Joust saying that the bill was written this way. And, I felt really good when he said it, because that's what we were trying to do. The biggest gain were in people that were at below 100% of the federal poverty level. That is no money. And so you see, from an income perspective, the bill targeted the people who needed it the most. And not many of our bills do that. Then you look at the race and ethnicity, and clearly African Americans and Latinos did very, very well. They have a long way to go, but they did very well. And that, again, was one of the things we wanted to be sure would happen. So while it wasn't perfect, while it had a lot of things we could improve and should improve, it had achieved a good bit, and frankly, we were very pleased with the road we were on. Now we have to say what's happened. You saw how hard they worked to repeal it. They cut the time for people in open enrollment from 3 months to 1 month. They cut the budget to help them enroll. 90% of the budget was put out. And you know what? The new numbers show, with the budget and with the open enrollment, we got 12.1 million people enrolled the year before. This year we got 11.9 million people enrolled, or 11.8 million people enrolled. And that was because, first of all, people loved the coverage they had, or really at least liked the coverage they had. And secondly, people really worked hard to get the message out, even without the help. The elimination of the individual mandate. Now this is going to be a real problem for everybody. They've now trying to legalize and encourage the sale of short-term health plans, and the White House stopped paying the cost-sharing subsidies. Actually, in doing that, they thought they would implode the insurance company, but they didn't read the bill well. What that ended up doing was, because the way we wrote the bill was that if you were eligible for a subsidy, you couldn't be asked to spend more than X% of your disposable income in health care, because that's the reason people didn't have it. You can't ask people to spend 70% of their paycheck in health care. So the rest of it would be a subsidy by the government. So what they did was increase the subsidy that the government was paying, not much more than a dollar or two of what the enrollee was paying. So it backfired on folks, but at the same time, a lot of it gave people a sense that, well, okay, it's not there anymore. There's no point in my signing up. And we've already lost 3 million people have gone off health insurance. The Congressional Budget Office says over the life of the tax bill, 13 million Americans will lose health insurance. So what do we think is going to happen in the coming years, months? We're probably not going to have a repeal of the ACA, but we do have a strategy of a death by 1,000 cuts between regulations they're putting in, the risk corridor funding that they cut. Now we have a number of states saying, "Oh, I want to make the people on Medicaid, I don't want them to freeload. I want them to have to work." Well, most of the people on Medicaid are elderly, children, or the disabled. When we were looking at the ACA, we studied the adults on Medicaid, and over 80% of them who were, numerically were of an age and stage that they could work, were working either 1 or 2 jobs. But, so at first I thought, well, okay, go ahead. It's not going to, that's not a big number of people. But what happened, someone took me back to the history when they started you have to have a work requirement for food stamps. And just the publicity, they say you've got to have work requirements for food stamps, or you've got to have work requirements for Medicaid. They don't say that is if you can work and this counts as work, that counts as work, the other thing counts as work. No, they just say you got to work. And so many people thought, I can't work, so there's no point in going to try to get my food stamps. 700,000 people fell off food stamps. And they were people that were poor, disabled, elderly. So we do have our work cut out for us in translating the reality of what that means to people, but we will get there. The 340B, now that's a highly technical drug program that is designed to help hospitals that are caring for a huge number of very poor patients, Medicaid patients, charity care patients, poor Medicare patients even. And I can tell you, as someone who ran a hospital for years, you can't pay for the drugs that people need who have cancer out of the Medicaid or the Medicare budget. Reimbursement that you get. So a doctor, to take them into his office or her office and give them the chemotherapy they need, would lose a fortune. Plus, oftentimes it takes a couple of hours to do that treatment. So because we could buy them at a less expensive rate with this 340B program, we could have a chemotherapy unit in the hospital, and the doctor could come down and order it and see the patient, but he didn't have to, or she didn't have to buy the drug and lose a ton of money on that. And so it, in many ways, helps hospitals who really want to do the right thing for poor folks. The cuts in enrollment funding that I talked about, I think we're going to see more of that. It's interesting, yesterday when the numbers came out, the person who's second in charge at HHS said, well, it just goes to show you how wonderful and efficient we were. I'm not going to go there. Anyway, there's some positive things to watch. Governor Hickenlooper of Colorado, Governor Kasich, have a bipartisan effort to try to get some sanity into things that need to be fixed. The rural areas of our country did not do as well because they often are not attractive to insurance companies and insurance markets. And so Senator Bennett of Colorado and Senator Keehan of Virginia are working on a Medicare X bill that will be helpful to everybody, but it'll first go after helping that rural, the farmer, the people that live in rural areas and find it very hard to get care. It's not ready for prime time yet, but they're working on it, and they're doing a lot of listening to people before they put it out as prime time. Senator Alexander from Tennessee, a Republican, and Senator Murray from Washington State, a Democrat, are continuing to work to try to get, they're what I call the adults in the Senate, to try to get some of the things done that will stabilize the insurance market. So I think there are people working hard, but we have to look at the future of healthcare in this country, and we are at, I think, another pivotal moment. The costs are going up and up. Just this last month, the cost for a drug that's been around for years for lymphoma and Hodgkin's went up 1,400%. It's the same drug. It's not a new miracle. It's not a miracle drug that we just found. This drug's been around forever. And there's no ability to stop that. We've got to deal with those kinds of things. And I think the American public is getting fed up enough that we may be at a tipping point. As I told you, coverage is slipping. And if we don't do something, we'll prove the Congressional Budget Office true and have 13 million Americans lose health insurance. That will cost every other American who has health insurance because those costs get shifted into your costs. There are massive changes in healthcare financing with some of the government programs. I talked to you about the short term, the ones that are saying, well, you can have a skinny plan now. You don't have to cover everything. Well, that's the whole premise of insurance. So then you're going to get all the healthy people out of it, and then the pot of people in general insurance will be the sickest people. It's sort of like, who complains when their house doesn't burn down that they didn't get to use their fire insurance? That's the whole beauty of being together in an insurance plan. And it's also the beauty of when you're young, you don't use it that much, except in certain cases, and you really do need it. And as you get older, you use it more, and there are more people coming up. So those kinds of changes that are being allowed, or at least trying to be allowed, and remember, There are some things people are trying to do that are against the law because the ACA was not repealed. I say to you, the most serious problem we have to face is, as a nation, we do not have a national policy on healthcare delivery. We have the biggest mishmash of ways of doing it. We have private insurance. We have insurance through your employer. We have Medicaid, which is 50 states, plus the District of Columbia, plus the territories, all different plans, all different categories for eligibility, and, you know, states that butt up against each other. And so you've got 3 different plans there. We've got the commercial insurance, and they are among the best stocks on Wall Street. I always say we need to be careful in this nation when it's more beneficial to be a stockholder of an insurance company than a policyholder. So we are spending a lot of the healthcare dollar not on healthcare. And that's going to take an informed public. Coverage is being used as a bargaining chip. We saw that in the fight for the ACA. And we have an uncharted future of healthcare financing because there's no telling what will come next, what regulation they'll try to approve, or what funding they'll cut. Increasingly, we have many, many needs and options. We have new treatments. You just think about it for a minute. And when I talk to healthcare audiences, they're just like, oh, how many of the people ever thought that one of the biggest problems this country would face in the last 2 or 3 years was how to deal with Ebola? We spent millions in healthcare on Ebola. Millions to be sure we could protect ourselves. It was the right thing to do, but who thought? And we had Zika. You know, we've got an increased number of elderly. We know that's happening. And we have, for the first time in the last 2 years, epidemiologists are telling us that babies born have a lower life expectancy than their parents. You know, that we're dropping the life expectancy down. That's a serious concern. And a good bit of that is the impact of lifestyle. And, that's simple things like obesity, lack of exercise, nutrition, all the way up to the opioid crisis. You know, we're 4% of the world's population. We're 27% of the world's opioid deaths. That is an incredible statistic. I was just with the Geisinger Health System up in Danville, Pennsylvania. Now, you know Danville, Pennsylvania, it is about as rural as life gets. And the president of Geisinger Health System, and it's a very, very excellent health system, a big health system in the state of Pennsylvania. He said a person in Danville, Pennsylvania is 4 times more likely to die of an opioid overdose than a person in New York City. I was stunned. I could not believe it. And then I saw some stats about rural life. And, we're ignoring some of these stats, both on drug use, on early sexual behavior, and early pregnancy, early teen pregnancies. So we really do have to take the lifestyle piece very seriously. We're coping with potential pressure to decrease healthcare spending, those of us in the healthcare field, and that's you just don't want to see that get to the point where we compromise choices in providing quality and enough staff. It's, I think, a time to challenge where the real non-value-added costs are in healthcare. In the structure and the cost of administration, the cost of stock dividends, the massive marketing costs. I mean, 80% of the ads on television are drugs and insurance. I mean, do you just ask somebody what it costs to put a 1-minute ad on television? Medicaid, I told you about. The unbridled cost of pharmaceuticals and medical devices. And many people don't realize, but part of the political power of the pharmaceutical industry is that they have it in the Medicare law that the government can't mandate in the Medicare program that people use generic drugs if they're available. And so, somebody just did a study and said, if we had used generic, they looked at the drugs being used in the major Medicare generic drugs, the same drug, but the generic version of it in Medicare, over the last 3 years, we would have saved the Medicare program $3.4 billion. But by law, we can't. That's the power of the pharmaceuticals political wing. It's not as big a power as the NRA, but it's certainly getting there. And so I think we in healthcare have to find ways to streamline care, to increase quality and decrease costs, that ways that have integrity, such as the coordination of care teams, technology being used better and more effectively. We also have to be humble enough to learn from other countries and look at the percent of their non-healthcare budget that addresses the social determinants of health. Because so much of what we deal with in healthcare that makes life so expensive is the fact that we don't have the social network that we often find in particularly the 7 or 8 top industrialized nations. We need to mine the potential of population health to lower the cost. But we must insist as a nation that you can't make healthcare better and lower cost with millions of uninsured, especially if the millions of uninsured are in the lowest income bracket in our country. It's basic economics. It doesn't take a degree in business to realize you're not going to be able to make healthcare affordable for everybody when you leave millions of people without any coverage at all. We have to look at what's going to happen with the new players in the marketplace. I'm going to watch these very closely. Some of them, I think, are going to have the same response that our president had when he was, going to whip a new health plan into shape quickly. Who knew healthcare was so complicated? But it is going to be something that, and we can learn some things from them. What's our responsibility? I believe that all of us, no matter where we are on the spectrum of citizenship and involvement in healthcare, need to know the facts much more clearly. There's so much bad information out there. We need to have a concern for everybody. We need to speak up for the common good. I know it is often in today's parlance, particularly in the DC environment, poo-pooed and seen as stupid, and we need to reinvigorate the concern for the common good. We need to reinvigorate the dignity of life. And for many of us, the sad part is so many of these people that don't have insurance, that can't take care of their children, these are people who wait on us every single day. And we need to think about the overall good of the country. It's not good to have a country where 50 million people don't have health insurance. It is not good to have to admit that we have 9 million children that didn't have health insurance. We've gotten that down, but it's going to go right back up if these folks have their way. And they've got, quite frankly, a lot of other plans, such as moving the Medicaid program from a federal program to only a state program with a limit on what the feds will do. That will be catastrophic. Their other plan is to take Medicare, and instead of letting you have a choice between a Medicare Advantage plan or traditional Medicare, everybody would be given a voucher. And you go out and find a plan that you can buy with your voucher. Hopefully there's one that you don't have to spend too much of your own money, or one that if you don't have any money, you can get for that. But the truth of the matter is, when I'm 85, I do not want to be shopping every year for an insurance plan. We need to give seniors peace and security and not to have to deal with all that. So I think we have to say, what does Catholic social teaching call us to? And I think it's to advance the narrative that assuring health care that is available to all is first the responsibility of a government to its people, similar to its other programs such as food stamps, welfare, police protection, education. And we really will not be able to do this until we can get we won't get an excellent system of healthcare delivery and good basic healthcare until we get more political stability and a reasonable national health policy. And I honestly believe that we've got to keep pushing for that, because everything else is only a Band-Aid. And we in Catholic Healthcare are certainly going to try to be a part of that. And I would say, when you look at Catholic healthcare, sometimes I say to people, remember, this is not our first rodeo. The hospital I was CEO of, I was also born in, and it was on Capitol Hill when I was born there. But when it was first established and chartered by President Lincoln, we reported to the War Department. Our finance committee was the House Ways and Means Committee. So when I was the president and the staff would be belly aching because our finance committee was tough on us, I would say, it could be the House Ways and Means Committee kids. So, this is not our first rodeo in Catholic healthcare. We've been through the Great Depression. We've been through world wars, civil wars, all of those. And I often say to people, I think the gift of our Catholic healthcare to our nation is our ability to take the long view and to stay at the task. And there's a beautiful excerpt from a poem that I try to say to folks when they're a little discouraged in Catholic healthcare about what's going to happen. Can we be like drops of water falling on the stone, slushing, breaking, dispersing in air, weaker than the stone by far? But be aware that as time goes by, the rock will wear away and the water comes again. So we will keep at it, and I hope and pray that you will keep at it as well for the good of our nation and for the common good. And thank you, and I'd be open to any questions or comments. Yes.
Thank you so much, Sister Carol. I support everything you said, but in the interest of conversation, what would be the best argument from those who opposed the passage of the Affordable Care Act, especially if they were thinking from a Catholic perspective, as many at that time did? I repeat, I agree with you, but for the sake of conversation, what's the best argument on the other side that you would have to deal with?
What we had to do was misinformation. It was constant misinformation, and the leading misinformation from Catholics was that it was going to be a huge expansion of abortion. From others was often, I would get letters from people saying to me, do not dare support that Affordable Care Act. I do not want government-run health insurance. I'm on Medicare. You'd say a civics lesson would go a long way. Then, we had, and actually we have a slide on this, that it was going to be a job killer. Many people were just going to go out of business because they couldn't afford it. It was a job expander. So, frankly, one of the things you have to understand is this was President Obama and a Democratic Congress. Now, we had many solid citizens among the Republicans who really wanted to do this, but they were stymied. But Senator McConnell, who was the minority leader in the Senate when President Obama was inaugurated, and he ran on health care. He said the day the president was inaugurated, my major goal in the next 4 years is to assure that he does not get reelected. So there wasn't like you could say, I know you think it's going to do this, but It doesn't. And so there was a lot of pressure. You had people in the Senate like Olympia Snowe from Maine, Susan Collins from Maine, a number of people like that who really, really wanted to support it, wanted to have a bipartisan conversation, wanted to bring a bipartisan bill to the floor, couldn't. And it was a lot of the stuff that was out there was simply, it was socialist. We're going to be, and when they said, let's do the thing where we'll tell people, let people make their living will, decide what they want when they're terminally ill and who they want to make the decisions. There you go. It's a government death panel. And so, it was the misinformation that was locked in, and that's still out there. I mean, there are still people who think if you get 70, you're not going to get insulin, and you can't get your hip replaced. Yes.
Thank you, Sister. So, if I'm not mistaken, the ACA was designed and modeled on a plan that was very similar to or identical with a plan originally formulated out of the Heritage Foundation as an alternative, as a market alternative to the fear of going single payer or public option. And it was what we had in the ACA was then, prior to becoming the ACA, it was similar to the plan that was run in Massachusetts under Romney. And we know that the single payer option was very quickly taken off the table. The public option was sort of floated as a distraction from single payer being taken off the table, but then that was taken off the table. And both of these, probably because of the influence of the insurance industry and big pharma. So there's a sense in which the problems that you're identifying, I think, with current movements against the ACA, those are problems that are, I would argue, endemic to the ACA itself. You had the ACA, you had the markets in Obamacare were not working. Big insurers were pulling out of smaller pools. So long as it was you could make the case that the ACA was designed to maximize insurance profits as much as you could make the case that it was designed to extend coverage, because if you equate having coverage with buying insurance, you're doing both at the same time. And to me, it seems really interesting that Obama had a supermajority, I think, if I'm not incorrect, or a majority at the time it passed. And if the Democratic Party had wanted to put forward some kind of real healthcare reform, they could have done it. And they don't want to do it. And so, so this is interesting to me, because now, in 42 states, more than 50% of the population in 42 states support single payer, support Medicare for all. I just don't think you're ever going to solve the problems that you're addressing if the solution to those problems is getting people insured. So I was wondering, do you have a stance on this personally, or
let me just say,
the Catholic Health Association? Because
a lot of what you say is absolutely correct, and that's why I said when I started, it's not the bill I would have passed, and it's not the bill Obama would have passed. Okay, it's a bill he signed because it was the bill we could get, and it was a step forward. It was not perfect. And now let me just say this to you. Part of it was based on the heritage, because a part of it early on was, all right, let's hear your ideas, and let's, there was a constant thing of, if we give a little to the Republicans, we model it a little on Massachusetts under Romney, we take some of their ideas, we'll be able to get them to come along. They were never going to come along. He did not have the votes to get a public policy, to get a public option, and he would have lost it, because they were so effective at saying, if you get a public option, you're going to lose your, and you remember we had a big union presence, And the unions did not want to lose employer-sponsored. And so he didn't have, I mean, as somebody who sat in the White House and sat in the Senate Finance Committee hearings, I can tell you he didn't have the votes to do that, but and we knew that they would have lost it. And when I say to get everybody insurance, I don't necessarily mean commercial insurance. I mean coverage, some kind of insurance coverage, like you have in some other countries where you have insurance that everybody can have, and then if you want a little bit better choice or you want a private room or whatever, you can get a little on top. It's sort of like in a house. You want a small apartment, you can get that. You want a house on the lake, that takes a little bit more money. So you're absolutely right. It was in many ways a hodgepodge of some of the stuff that came out of the heritage and efforts, and some that came out of Massachusetts. Early on, it was an effort to try to bring on some of the Republicans. That was never going to happen because of the threats they received. And the public option, you had too many union and other people saying, I don't want a public option. Now we have more people saying, I've had my fill of insurance. So I think the moment is moving there, and I'm very happy about it. Yes.
Thank you, Sister. This is changing the direction of the conversation just a little bit with my question. But I'm wondering, as a clinician, what your answer would be, or what the CHA's role can be in protecting the rights of clinicians to practice medicine in line with Catholic teaching, if our Catholic medical institutions come under increasing federal healthcare control, especially in a case where our culture continues to become more hostile to Catholic teaching. Thank you.
That's a very good question. And one of the things that, we still have the Hyde Amendment, we still have Weldon, we have the Church, Amendment. So, and we continue to push the importance of those, and we continue to push back on when a regulation comes out, to push back and say, wait a minute, in a pluralistic country, if you are insisting that people have a right to do this, then we're insisting that we have a right not to do it. I would say one of the things we need to do is be really clear on what's reasonable conscience protection for me and what's reasonable conscience protection for others. And sometimes people have taken that to a little hurtful. And in fact, when they announced the HHS Office of Conscience Protection about 3 or 4 months ago, the first thing that people said was, this will give Catholic hospitals the right to refuse to treat LGBT patients and transgender. I had to come out very quickly and say, there are some things that we will not do in our hospitals because of our conscience. But what we do in our hospitals, you are welcome to partake of. We welcome you as a transgender patient, as an LGBT patient, like we welcome everybody else. Those same patients have heart attacks, auto accidents, gallbladder attacks, and we would love to take care of you in our facilities. So sometimes I think and this is just sort of a personal take on it, but I think when you decide that I'm not going to serve gay people in my restaurant, and that's my conscience protection, or I'm not going to bake a cake for a wedding, I think to some extent we've got to say, wait a minute, if I want my conscience protected, I have to protect the conscience of the other, and there needs to be charity and goodwill. And sometimes it hasn't always been that way on both sides of the equation. And we need to be represented in our church and in our healthcare, as well as in our education systems, not by the fringe on either side of that. But it's a very important point that we spend a lot of time on. Was there somebody over here? Yes, excuse me.
Yes, hi. Good evening.
Good evening.
Sister Carol, thank you so much for being here this evening. I am one of your guests that tonight, fortunately, do disagree with much of what you said tonight. And but one of your first slides, my main question is to deal with the economics aspects of that. But one of your very first slides was the Catholic's right to health care. You know, I've always seen it more of a privilege, given the different gifts and talents and why a physician goes into their, you know, respective practice. But when you're looking at the economics, I was wondering, and here's my question, is when you're looking at, I believe this, the dollar amounts was about $7,300 per participant within our healthcare within the United States. Does the population factor at all within your economics? I mean, when you're looking at Australia being 8 million, us being 325 million, Canada being 30 million with the same amount of square miles, you know, does that figure at all with the figures and what we're able to do as a body within the United States? And you know, I'm just open to hearing what you'd have to say.
You know, there are a lot of things you can go into. You know, Canada is such a vast area, and most of Canada's population is very concentrated. Australia, right? Oh, you're absolutely right. And this is a per capita cost. So yeah, and you can say, for instance, in this country, it's a lot cheaper to take care of the people in Utah than it is in New York. The Utah lifestyle is a lot more amenable to healthy living. You know, most of the Mormon population don't drink, don't smoke. They live a much more healthy lifestyle than we do. So you can take all those kinds of factors, but you're looking at a per capita, and then if you can also take it and use it as a gross domestic product measurement, we clearly cost more per anything in healthcare than any of these other industrialized nations. And I'll tell you some of the things that drive those of us in healthcare crazy. You can take a pill or an injection, and what we have to pay for it from the same pharmaceutical company here, buy it in France, Italy, Australia, or Japan, the exact same drug from the exact same manufacturer at less than half of what we pay here. That is what drives much of healthcare costs. So yes, and the same is true with medical devices, whether it's a hip replacement or anything else. So when you look at healthcare costs, that includes everything. And so I would say to you, you could find something and say, well, for Canada versus U.S., they have it better here, but in some instances, U.S. has it better here, and make that case. But when you take the total of it all, none of that is enough to make a significant difference. If it were, the American studies would go at it like nobody's business. But no, everybody admits in healthcare that is the reality, and it's for many reasons. It's our healthcare delivery system, it's the cost of pharmaceuticals and the cost of medical devices, it's the demand of people in our country, and it's malpractice. But it's you probably were far superior to other people, because Minnesota tends to be, I don't know that it's lowered your bar, but quite frankly, and we'd have to look at that, but Minnesota's known for being people who care about each other. You know, people talk about Minnesota nice. I mean, you really, in many ways put us to shame, put the rest of us to shame, because you do have a sense, a much more of a sense of the common good. At least that's the way the rest of us view you.
Sister Carol, thank you so much for your presentation. I really enjoyed the very first slide with the history picture, and I'm wondering if you have any comments on how the church broadly went from having basically monopoly control over healthcare delivery to now being, at least based on your last few slides, more in the business of nudging government. That's a huge change of roles, and do you think that there is ever a role to get back to the way we used to do it?
No. Let me tell you why. I often, I'm getting old, and so I can say this very candidly. When I was a student nurse in a 3-year program, if you came in with chest pain to our emergency room, we would be very gracious and kind to you. We would put you on the stretcher. We would do an EKG. We would give you oxygen. We would give you some morphine or Demerol for your pain. And maybe if we were a teaching hospital, we had an echo machine, and we would put you on bed rest. In today's world, we have to be able to get you into the cath lab within 30 minutes. So that we can have a heart cath going to see if you need to have clot busters, or you need a stent, or what you need. We have to have interventional radiologists there, interventional cardiologists there. I mean, the standard, and the same is true if you have a stroke, the standards of care we give. Now, we have much better mortality and morbidity, but it's certainly paid for. If you came into my hospital with a gallbladder attack, what a moneymaker you would be, my darling. We would take you to the OR, and we would put you to sleep quickly, and it only took a surgeon and a scrub nurse and a circulating nurse and maybe a resident there or a tech holding retractors. We would slice you all the way around like this. We would go in, we would take your gallbladder out and sew you back up with this massive thing, and then we'd wake you up, and you would be sick as a dog for at least 8 days, and all we would do is give you anti-nausea and pain meds and encourage you to get up and walk, to get yourself feeling better and get stronger, and then you'd get better. But it was a long way to go. Now, if you come in, we've got to have the laparoscopic equipment that we can put a tiny little slit, just a tiny slit, and put a tube in and look at you on a television monitor, and with inside that tiny little tube, get our instruments in, take out that gallbladder, pull it out, and sew up this tiny little incision. And you know what? Some people go home the same day. Everybody else goes home the next day, unless they're very old and have some complications of a complicating medical condition. That costs a fortune. That equipment is millions. The technicians to run that are millions. Believe me, you would, if you ever saw it the other way, you would fall in love with this way. And I could go on and on and on, and I'm not going to, because I owe you an answer. I'm sorry.
Thanks. I think we maybe have time for
the other thing is,
one or two questions.
The other thing is the government, we moved into heavy duty with Medicare and Medicaid, government funding of the care of the elderly, and then insurance got bigger and bigger. So we just need to make sense out of the world we've got right now. Yes. We did. There was no way you could, and there was no way hospitals, people who got the care could afford to pay for the care, and so government moved in with the poor and the vulnerable, and with the elderly, and now people with insurance can hardly afford their care. So we need to make sense out of a system of healthcare delivery, and we haven't done that. You're absolutely right about that, but the past is not the model. Yes.
Thank you, Sister, for coming. My question has to do with healthy lifestyles. So I think you would agree, and most people would agree, that a substantial part of our healthcare costs are attributed to decisions that are made that are unhealthy by individuals.
Absolutely.
How do we encourage healthier decisions as a way of reducing the cost and the burden in the healthcare system, and should there be an economic factor for those who are making those type of decisions?
You know, I think there are legitimate, absolutely legitimate things to talk about in that area. I would love to say you can have, you know, there are certain things you know, if you're born with cystic fibrosis, you know, you've got bad lungs, and you know, we need to pull out the stops for you. But if you make your lungs bad because you smoke, you make your blood pressure and your heart, you know, and that's why I get nervous when people say, well, we ought to pay doctors on how well they keep people healthy. Well, if I'm 300 pounds and I smoke, and you give me the lecture every time I come in, and I give you the and walk out and continue that lifestyle, it's not your fault. But it ought to be my fault. And there ought to be a consequence and an incentive. If you know, people who keep, now I think that needs to be done fairly and with the right incentives. But I am all for it. I really am. Because I think it is just, it can't be. We just can't continue the way we're doing things. And America needs to know that this lifestyle is unsustainable.
I think I would like to propose that we actually move to the next room just beyond this wall where there's a little reception, and we can continue the conversation there, if you don't mind. Because now, given the time, I'm happy to stay. You're happy to stay? Would you mind taking a few more questions then? Okay. Okay.
Happy to stay.
Let's take a few more then.
Well, or I can go out in the reception area and talk to people.
Okay. Yeah,
I'm happy to do that.
But why don't we go to the reception area and continue the conversation? Please join me in thanking Sister Carol.